Hello, everyone, and good evening. Once again, it's the 10th of June, and as promised, 10th is the day for the Imaging Science Committee, and I, Neena Malhotra, welcome you to yet another exciting podcast. But before we take on the podcast and I welcome my guest, who is a celebrity, I take the pleasure to welcome my dear friend, Dr. Sunita Tandulwadkar, the president of Fogsi, the brainchild behind Gyan Pravah, the podcast series, which brings forth not just obstetricians and gynecologists, but a flair for us to interact with our seniors, colleagues, and give you back the best from this podcast. So, welcome, Dr. Sunita.
Thank you. Thank you, Nina. And I'm really proud of you, Nina, the way you conduct your podcast. Every 30 committee chairperson, they try to do. So, Dr. Kamini Rao, this Gyan Pravah series come every day at 8 p.m. On 130 committee chairpersons on 30 days. They come with academic, non-academic, spiritual, social, political, philosophical, any background they come. We had Central Ministry, Dr. Nitin Gadkari with us. We have many. And I felt that these committee chairperson, when they will have a 12 podcast in a year, they will be so evolved. In taking the interviews, having dialogue with the seniors. Nina is a seasoned Khiladi. She is a professor head at the AIMS. But there are many youngster committee chairperson who probably have never taken an interview, and it will give them a good oratory skill, also imagination. They will outreach to the people. And believe me, it became not for them, it became for me. Today is 133. Meeting so many faculty every night, I evolved as a person listening to them. It is fantastic the way people are working in their respective field. And I enjoy this dialogue or the conversation, 45 minutes between the two personnel. It's amazing journey. I think at the end we should come out with something very different, because 365 days, 99% we see to it that the faculty is not repeated. So it's always, and even if by chance got repeated, it is always the different subject they tackle. Personality like Dr. Kamini Rao can be taken by 10 people because she has so many different things of life to be explored. So thank you so much, Dr. Kamini. And I'm sure you have a nostalgic moment of your dynamic presidentship. I was very young in a Fogsi that time, but I was always amazed the way you used to work, not only in Fogsi, but even in ISAR and as an editor-in-chief for Human Reproductive Sciences. I have seen you closely working, and fantastic, a lot to learn, and now the great entrepreneur of the country, I must say. Thank you for coming on a Fogsi platform. And thank you, Nina, for getting Dr. Kamini Rao to us. Thank you.
Thank you, Sunita, for those kind words and giving us an impetus. And I would just inform my viewers, Dr. Sunita leaves no stone unturned. She works 24/7. And to tell you, she's just returned back from the European Congress, and you can see how lively she is, brimming with energy and giving us a reason to sort of celebrate this year with a champion like Sunita. So thank you so much, Dr. Sunita. So, as I bring forth this podcast in the month of June, I think this is a very special podcast, and special for very many reasons. Because not only I have a celebrated guest, but also a subject which is enthralling and is intriguing. Inspiring journeys, stories of heroes to guide our next generation of obstetrician gynecologists. And I think we're going to talk about stories of untold stories of heroes, told, yes, but untold. And before I really go on, I take the pleasure to introduce my celebrated guest, who is none other than Dr. Kamini Rao. To begin with, she had an early education at the Bishop Cotton's Girls High School in Bangalore, studied at the prestigious St. John's Medical College, where she pursued her MBBS and her post-graduation in OBGYN, and then moved on to UK to train with none other than Kyprios Nicolaides at the King's College Medicine in fetal medicine, including fetal invasive therapy. And then went on to train in Middleborough, UK under Professor Ray Gary. She came back to India, and then she had to her many firsts, the distinction of having set up the IVF unit in South India with the first semen bank, the first ICSI baby of South India, and then going sort of, stoppable, unstoppable. And I think she has worn many hats, from fetal medicine to reproductive medicine. She's a pioneer and a champion in the field of reproductive medicine. And not just stopping at reproductive medicine, she moved on to become an entrepreneur, being the chairman of the Kamini Rao Group of Hospitals. She is an avid teacher, passionate about what she does. And then I would like to inform you, she has a degree in law, which I think is untold even on the Wikipedia, bringing accolades for us to look up to her and be proud, with awards to name a few. And I think the list is endless. So I'll just kind of bring out that she has been awarded with the Padma Shri in 2014, the highest civilian award for her excellence in the field of medicine, including reproductive medicine, the Karnataka State Award for her Rajya Yotsava Award, the Vidya Ratna Award, the Lifetime Achievement Awards, and many, many, including the BC Roy Award from the Shimoga, and of course, Lifetime Achievement Awards from Fogsi. Dear friends, she has been the past president of Fogsi, chairperson, and I think to her credit, she has written many books which span from not just obstetrics and midwifery to everything in the field of reproductive medicine, including endoscopy, reproductive endocrinology, and I think the list goes endless from embryology. And I think I won't waste time, and I think we'll move ahead in sort of welcoming our dear senior, dear mentor to many, and of course somebody whom we look at. Welcome, Dr. Kamini.
Thank you, Nina. Thank you, Sunita. It's wonderful being here with you people, because we don't get time to talk to when we are in a conference. We are running from one hall to the other and then onto the flight. So we don't see the place, we don't sightsee. We are on the flight or off the flight, in the hall or out of the hall. But it's a good time now to just sit back and reminisce what can be different, how can we make it different, and what would be the goals.
Thank
They
you.
always say wine is always good in bottles that is vintage, and perhaps you can call me vintage now.
No way, no way. We can't dare to say that. But one more important thing, Dr. Kamini. Now, once she start the interview, I join the viewers link, and only two beautiful ladies will be in the frame. Number one, and number two, because this is not only heard by the gynae, but other faculty or anyone, because it goes on a YouTube. But those gynae youngsters who are knowing now we conduct the UR Foxy, I must tell Nina, UR Foxy was started by Kamini Rao in her Foxy presidential year. She had a special love for URs. Always she wanted to give them. See, these are the quality you observe, you learn, and you adopt, and you implement as well. My love for a UAs is probably sometimes inherited part from Dr. Kamini. She always wanted UA or Foxy, one UA giving the oration. So UA Foxy, I don't know whether Nina, you were aware that UA
Yes,
Foxy
I know.
is
That's
by
why
Dr.
I was
Kamini
about
Rao.
to speak that.
Yeah.
So you actually,
So
that's the reason why I chose this
that
topic.
is
We
a
know.
that is a footprint on the Foxy. We all come, we all go, but we need to keep some footprints. And Dr. Kamini's footprint in Foxy is UR Foxy gifted to all of us. And every year we have 4 zones, 4 URs. This weekend I'm going for a West UR Foxy itself. So lovely seeing both of you, and we enjoy your conversation while I enjoy you both from other link. Thank you.
Thank you.
Thank you,
Thank you.
Sunita. So truly, it's a youthful, podcast, because we know that Madam is the one who set she set the ball rolling on You Are Foxy, and no wonder we have a podcast which reads Inspiring Journey, where she's going to inspire the youth, the next generation of our obstetrician gynecologist trainees. So let's begin. I said I would just ask Dr. Kamini Rao, ma'am, what inspired you to pursue a career in reproductive medicine? I would say first in OBGY and then, of course, reproductive medicine. So what was your inspiration?
Well, my father is a gynecologist, and he was the first male gynecologist in the state of Karnataka. And those days, because in the south, we are a bit more conservative compared to the north and the west, and people were never accepting male gynecologists. It was only when things got complicated that the male gynecologist came to the fore. So in big government hospitals, my father used to be the final person when the complicated cases or was caused, simple cases became complicated. My father was called in to clear the mess. So that's how he earned his name of second look surgeries and a whole lot of fistulas and things like that. So I was wondering with my father, what does he do? Why does he take so long? And why does he not give a chance to the juniors? And I always used to do, I also used to wonder, he's all good, he's great, but skin to skin, very neatly, he will do. But the other person is either holding a retractor or swabbing, but they don't get anything else to do. And the one thing he told me was, see, Kamni, the patient has trust in me and they have given their body to me to sculpt. And just because they're under anesthesia, it doesn't mean I can just give it to somebody else. And that was my first learning what you should not do. Because what you can do very well, and if he did a SWOT analysis, you must give to the others. Because if something goes wrong, you're there to correct them. How long in a 1.4 billion population can you keep on doing surgery? You die of exhaustion syndrome. So I told my father, I don't be so tunnel visioned. If you're going to do it and if you're going to supervise people, no person is going to be, upset that you're government hospitals. But yet he still stuck to that point. So things that I learned from my father is what not to do. So this is like reverse engineering. The second point that I learned from my father was that you don't keep on putting too much of ALS and artery forceps on tissues. The only thing that should touch the tissue is knife and needle. That's it. So the less damage to the tissue, less ischemia to the tissue, the better they heal. And when I told my father, he went on these laparoscopic camps, where they went into schools and got those benches and things like this, and they did 30, 40, 10,000 laparoscopies in school premises. I said, that is not the type of cases I'm going to do. Because it's important, just because the numbers are high, you can't just go and say you got a laparoscope and you just swing the laparoscope around and do 20,000 camp patients. Because I wanted to give respect to the woman and see that the woman gets adequate anesthesia and, don't put them on an assembly line. So my thought process was totally different from the way my father thought. So since I come from a doctor family, and 5 siblings, I was the middle one. I was a rebel. I did it my way. I wouldn't take no for an answer. I would still say, I'm doing it this way. Now, getting into medicine was not by chance. It was because my father felt that I'm good in reading, so you should do medicine. But I wanted to do organic chemistry. I had maxed my papers in organic chemistry. I had a rank in the university. So I said, I want to be a college teacher, take honors in organic chemistry and teach. And I want to do research. Then my father said, no, with your brain, you can help a lot more people in doing medicine. He never gave me a chance. The only chance, he said, do you want to get into Bangalore Medical College or St. John's Medical College? So there was no third option. So I had to choose Bangalore Medical College. These days you have a lot of options. And therefore, with the mobile technology here and so much of opportunities, had I got this kind of opportunities, perhaps I may not have done medicine at all. So
That's nice
what
to
I
hear.
would put across to you, Nina, that it not only, confuses the youth, but the youth also need a direction. And to get the direction, they need to know the pros and cons. not the flavor of the season. This is not a fashion show. They must have a passion for the subject they're doing, and they must know why they're doing it and why they're not doing something else. That's where the basic lack of forethought is there, which causes confusion. There are people who have done MBBS and then gone into something else because they made a mistake. Therefore, plan 5 years in advance. I always say. So if I'm doing something today, this would have been thought 5 years ago. I just follow the map that I'm doing. Even if you don't do it, you do a mid-course correction, but have a map. That's my mantra.
Yeah. And, I just thought I will give you some figures before we move to the next question. I want to just pick it again from this digital platform that we have. We just was appalled to read that there are 23 lakh students who passed 12th and took the NEET exam to reach the undergraduate. And you have 118,000 UG seats today in India. And last year, it was 218,000 undergraduate MBBS students who were competing for the 73,157 odd postgraduate seats. And can you believe it? Out of these nearly 74,000 postgraduate seats, we just have close to 4,100 seats for OBGYN. So you can see how tough the competition grows from your class 12. And as ma'am says, a roadmap of 5 years we need to plan. I just have a question. For MBBS students who are so ambivalent, who are unsure of the path ahead, how can they explore the specialty of OBGYN, and how can we make, because we know that the path is tough. Obs and gynae, OBGYN is not an easy, it's definitely a more demanding specialty. But if we look at the numbers, where so many competing, how can you think we can guide them and we can attract more postgraduates to take OBG as a specialty and guide them better?
The biggest problem in our society is that most of them wear blinders. Many of them don't know why they want to take obstetrics and gynae. If you just have to sit down with them and ask them to write just 5 lines on why are they taking obstetrics and gynae and just quiz them about the subject, I'm going to tell you more than 50% will fail, because the objectives, the foundation is wrong. You have to believe in it not as a profession but as a passion, and you should dare to be different. Because what are you going to make a difference? What a midwife cannot do, what you're going to do. One. Second, obstetrics is not about delivering babies. So if you're thinking that you're taking obstetrics to deliver babies and that's the moolah that you're going to get, I'm sorry, today in the National Rural Health Mission program, the government hospitals are so good that in many of the private nursing homes are now going empty while they do the antenatals there. For the deliveries, they're going into the government hospitals. See, the situation changes. It's very dynamic. And one has to understand what is here today is not there tomorrow. And what got you here to the MBBS is not going to get you to MD. So you can't use the same yardstick of what you're thinking of. So if you're thinking of trying to do obstetrics and gynae, there must be a clear-cut plan for you. Are you going to subspecialize? So it means not only the MD, which is 3 years, I think after 3 years, subspecialization will take you another 2 years. My advice to the doctors is that the sabbatical that they have for 6 months in the second year of MD, it should be, value add to the students. Like they could take up endoscopy, they could take up IVF, or they could take up urology or gynec oncology and do the same thing rather than go for rural postings or go in and do pediatrics or go and do anesthesia, because they were never going to go and do practice anesthesia. But all of them are clamoring to do ART, etc. Now, a person who passes through the post-graduation, why should she clamor again and go and do another 1 year of reproductive medicine? what is that 6 months there where they will be able to understand what it's all about? I believe that NMC should be able to remodel the curriculum and do subjects, subspecialties, even though the government hospitals all don't have, but you'll have to look at the supply and demand, and the need will create the demand. So if you don't have IVF services, then create IVF services in the government hospital. Why should only the private sector be the cream de la cream people to be able to afford IVF? I think the government hospital is a fundamental right. So in the government hospitals, there must be IVF. In the government hospitals, they must have endoscopy. And the elective postings must be in those specialties rather than the students passing out of MD and then going again for these courses. There should be gynec urology, gynec oncology, gynec ultrasound. There should be, the ART. There should be, different subspecialties. So by the time they go into the final year, they would have made their mind up on what subspecialty they would like to do. But what happens in our system is they have to finish the MD and then they have to get into ART. So what happens with, because I am recognized as an FNB teacher and the national board has recognized me as an outstanding teacher, but I find the system in MD woefully inadequate. Because before they start doing independent surgery, already 1 year is over. And then they will say how many hysterectomy you've done or how much have you done. The idea is once they've done MBBS, there must be a clear curricular path for them as to what are they going to do different from what the midwife is doing. I don't want both midwife and the doctor clamoring for the deliveries and episiotomies. Second, I believe that after MBBS, the MD doctor should be given a free hand to do hysterectomies and particularly vaginal hysterectomies. The MD doctor should be able to do breech deliveries, twin deliveries, and of course, placenta previa, etc. Suppose senior residents keep doing those and the MDs don't get a chance, they'll be doing cesareans for everything. So, if you say that you can work only 40 hours a week, how will a student get adequate, experience? I think many of them would have passed through MD without having seen a breech delivery, for example, or a transverse line. And the best example of a breech delivery is a 6-foot man sitting in a British Leyland Mini, sticking his bum out, and then one leg out, and the other leg out, and then taking his head out. And that is the best example of a breech extraction. Because you find that breech, all these singleton breeches are being sectioned. So this thing is the teaching pattern and the art of obstetrics has gone. And I would like to put that across.
I think you rightly said there's sometimes we pay the price of getting increasing our numbers. And would share that a lot of ESI hospitals, which are beyond 250 bedded hospitals, are being upgraded as medical schools. And I think when we're increasing the numbers of postgraduate seats, I think the fair share what a postgraduate get is going to be lesser. I think this is definitely a downside of increasing them. But I think what you really voiced is true, that I think we need to rejig our curriculum and think how can we get them skills more than the theory. I just want to ask you, I'm sure there would have been a lot of challenges and turning points in your life, in your career while doing MBBS or your post-graduation, which really sort of took you to take a decision and shape your career as to see what you are today. I don't mean today, but on your career path when you were charting some untraveled, journeys as maybe as a reproductive medicine specialist, and then law, and then probably an entrepreneur. So could you tell us something which was really, really, you could recall, which was really, yeah, a memorable moment? And yes, this was something which
Nina,
shaped me
in
what
fact,
I am.
every stage in my life has been an uphill task because there was no road to walk on, nor could I have driven any car because there was no path to go. So I not only had to create a path for myself, and then I had to walk on it. And this is something which people always fear. I believe today that the middle path is always crowded. People fear to get to the next level, which is absolutely a vacuum. You don't have competition. But people still want to take the safe path of being in the mid path where it is crowded and mushroomed and whatever, whatever. Their cat eats cat and dog eats dog. So they remain in that kind of space and the mind gets closed. So they start thinking from the spinal cord. You got a God given brain. You must understand how can I be different? Now, when I got my MD seat, at that time, there was some kind of political this thing about my caste, and therefore my seat was withheld, even though I was CET number one. They had given it to a socially economically backward student. So my father said, okay, you try once again. Then I said, why once again? I've already got it here and they've taken it away from me and I'm going to fight. So I put my case in the High Court. Those days it was never heard of going to the High Court. And then also a woman going to the High Court, not heard of. And my father said, why you want to get yourself exposed? I said, what am I exposed? I'm not going out naked. I'm just going there and I put a case. And it is my right. I went there and I fought for it. And during that time, the judge that was there called the director of health services, who were all in charge of the selection. And the case went on for 3 months. So during the 3 months, I found a pathology job as an assistant professor there because it was a kind of a locum job. So I got into that job, learning how to cut the uterus specimen, the ovary specimens and all that, and to be able to give it to the pathologist. But at least I knew how to cut those specimens and give it to. So I didn't waste time. And then went back and I won my case. And then my father said, yeah, very good, very good. But he didn't want me to do that. You see, because they have a very middle class mentality. Why be recognized? I want to get recognized. See, any kind of publicity is good publicity. So I took it, went there, I fought the case, and I came out. And that's how I got Nike. And the director of health services will see, you got in, let me see how you'll get out. I came out, I had passed, there were 13 students, 11 had failed, 2 only had passed, and I was one of the 2. And there was no need to fail so many people. But you see, this kind of vendetta people have is really not correct. What you may have in a classroom or when the students work with you, etc., is different. But when it comes to an exam, you have to be fair. I don't find that. I would scold the student, etc., in a constructive way. But here, during our times, they were all, old-fashioned treatment. They wouldn't read much. All they knew was hysterectomy or cesarean or normal delivery, whatever. They wouldn't update their knowledge. And I was the type of person, way back when I did my PG 1981 and all, I was talking about FSH and I was talking about LH, I was talking about primary amenorrhea and I was talking about a whole lot of syndromes, etc. And they didn't like me talking. So I said, tough luck. If you're discussing primary amenorrhea, we're going to be discussing like this. So They said, no, 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 no. Take another topic. What was the other topic? Normal delivery. Now, what do you expect out of that? What will the students learn? And where did I go and get all the FSH LH done? I used to go to the Indian Institute of Science. Those Mackay monkeys used to be there because they used to do that. So while they were doing that, I used to also get the FSH for all the patients there in Vani Vilas Hospital. And I used to run the samples there. Now, would you expect a doctor today taking that much of interest, getting the results and working up a case? That is passion. This is profession. When you have passion, you'll go right to the end. I want doctors to have that passion, fire in the belly, and I'm telling you, you don't need any help. You will go to the top and you cross that barrier, mid barrier, which is crowded and it is vacuum, you'll have no competition.
Rightly said. So, do you think as our postgraduates are getting lured or attracted to reproductive medicine or maybe gynecology or whatever they see, is there not much of a rush towards choosing ART as a panacea to sort of their success? Because as you'd say, if you follow the mid path, you don't reach. So go to something which is, untraveled land. So how do you see this kind of a boom that's moving, or the magnetism of our subspecialty? Where do you see this coming in the last, I would say, 10 years? How would you sort of rate this, and what would be your advice to people who, after postgraduate degrees and MDs, are ambivalent, whether to take a fellowship or a MCH, and how do you see that as in today's
Well, you see,
youth?
had I been talking to you in 1990s, I would be talking something different. Had I been talking to you in 2000, 2010, I'd be telling you something different. But today I am in 2025. So my version is going to be totally different. And the version is that if you keep on doing the same thing, you'll get the same result. However, our doctors don't realize. They say, oh, they did IVF, but we'll do IVF. Same. So you'll get a failure. So there are many patients who come with 6 IVF failures. Okay. And then say, what will you do different? No, I'll use a different drug. The problem is somewhere and you're doing something else. So what happens is, one, not knowing the subject properly. And the second thing over there is that somehow, by hook or crook, I have to keep the patient with me. They're all very hunky-dory when the patient walks in. But when the beta-HCG results come, the junior-most doctor is actually treating them. The first thing is to learn empathy. Second, be transparent. And third, ability to say, I don't know. Then patients will be forgiving. But every time to say, I got 80% success, 90% success, your egg in your hand in 24 hours, all these kind of advertisements is only going to kill you. Because patients also want to have a frank chat. If in the beginning you're promising the world to them and then you say, no, I'm not God, I'm not this and all, then better tell them right in the beginning. You can't pump them up and then bring them down. Now, suppose it was in, say, 2000, early 2000, there was still an unmet need in the population and not many centers had come up. So I would say that it had not saturated. Today, what has happened is the market is saturated. The market is not saturated for the good IVF centers. It is saturated for those that are mushrooming. Those that have done, illegal things. Ever since the ART law has come in, there is some semblance of, legislation, regulation. So what happens is, now and then, this regulator takes the danda and keeps doing like this, and all the children fall in line. But if today also you want to be a success, there's no point in putting 200 centers, 300 centers, by just putting, in your maternity ward, one more extra room, and then call that a center. Because what you're trying to do is create a chain. But you can't replicate, because what you lack now is human personnel who are trained. So on one side, infrastructure can come because you can throw money with deep pockets. But how long does it take to train an IVF specialist? It's not a low-hanging fruit. They'll say, okay, they're training technicians. They're not training consultants. That is something that you have to worry about. What happens to the integrity of the embryologists? You have to worry about that. And how many autosomal recessive disorders are we now bringing to light because of ICSI? So what had been eliminated earlier, we are now bringing it to the forefront. However, if you say, is everything gloomy? I will say, no, it's not gloomy. It's quite bright. Why is it bright? Because suppose now you're looking at, artificial sperms, artificial egg, using of fibroblasts or the skin. And so you may do away with third-party reproduction. You really will do away with this given another 5 years. Secondly, you will also look at orphan diseases, galactosemia, and a whole lot of Duchenne muscular dystrophy, or thalassemia, sickle cell anemia, fragile X. You don't have to wait for them to come to you. Go to the public hospitals and you'll see that there are clinics running with these patients. Go and do it. Get your data. Come to a subspecialty level where you can present this data to the outside world. We are sadly lacking in data. And if this is presented, it is a gold mine. But who wants to do that? Because that doesn't give you money immediately. Everyone wants to look at the rupees and a paisa in the pocket. And if the person is really interested, then they will do this. Then they'll get collaborated. Either DBT will do it or your ICMR will do it, but they don't know how to write a grant. These are the things that has to be taught to the students in the reproductive medicine, so that they know how to write a grant and get a grant and to be able to do trials. I can show so many intelligent students rotting because they have no guidance. No guidance. Tell me how many papers are prospective, randomized, case controlled? Nothing. All retrospective data, all collected fudged data, and you've got them all put in so that everyone can climb up the ladder in the medical college. What more can I say?
In fact, you answered my question, because I was putting next, how important is research in the journey of our postgraduates and our young trainees, and how do they strike a balance? So I think you really put it so nicely that at the end of the day, research is what needs to be pushed.
Absolutely.
That's where
Absolutely.
whet
At
our
least
skills and also our knowledge.
10% of your income must be put into research. And I have put 30% of my income into research.
And that's what you're reaping the fruits today, I would say, truly. The right investment, the return on investment is how you put it in the right
It's
way.
not monetary, but the visibility and the respectability is so much more, and you can only eat twice a day. Okay. This is so much more amazing. And I learned about it right in 1980s after I came back. This was not with me. And my father used to say, "You're a stupid woman. Why are you teaching so many people? You came and somebody else will take it away." I said, "No. 2 and 2 will make 22. If I teach, there'll be 100 people will benefit out of that. And that's what I want to do." So that's why there are thousands of students.
Definitely, as a chairperson and the lead of the International Institute of Training and Research in Reproductive Medicine, you've set the bar is so high that I think all of us as juniors look up to you. I just would, I think, a little bit of, fun that I would get in this podcast. If you were a postgraduate today and you were pursuing your career, would you, or maybe you were probably, maybe you said you would do, you would have done, how would you have sort of taken things today in 2025 while you're pursuing your MD in OBGYN? Would you have still fallen to reproductive medicine, or you could sort of, after, having tasted fetal medicine, reproductive medicine, and then so much that you have? So I'm just kind of,
I think, see, reproductive medicine is a profession for me, but fetal medicine is a passion for me. Because that time when I did fetal medicine, like, doing biopsies, fetoscopy, as well as all these things, it was so new that I was very premature in my country. People said, what? Search and destroy. That's all. Search, conserve, and deliver was not the mantra. They were asking me, what is photosynthesis? What is fetal reduction? So, in fact, when I came, they asked me in HN hospital to show them a fetal reduction. So I showed them the fetal reduction. And the first book that came out also was an introduction to genetics and fetal medicine. I actually brought the concept of writing books to Fogsi. There are 54 textbooks and 9 textbooks in nutrition, chrononutrition. If you took the same meal at different times of the day, how does it affect your fertility? You see, these are very small things. But when you understand that, the big things will take care of themselves. And this just came out because a woman came and told me, you're saying balanced diet, balanced diet. I come from North India. Can you please write on a balanced diet? Most of us escape by saying take proper protein, carbohydrates, and many of them will not understand. So she stumped me. Please tell me. I didn't give up. I asked her to go and sit there outside. And I started rummaging through the net. And I made one week plan for her. And also the vegetables and all, mix and match, etc. And then I calculated how much calories, proteins, fats, etc. And I gave it to her. The reason I did that was it was helping me that in future, I don't have to act dumb. How many gynecologists will sit and say, take Horlicks or go and do this with, Rajma or something? Nobody will take interest. But this is what makes a doctor different from another doctor. Because you touch the patient's heart. These are small things.
yes. And just, I think before, I think we have a couple of minutes more to go, but I'd say, what do you see today, after having done for the last 40, 45 years, such a glorious, illustrious journey that you had, which has been so inspiring? What do you see as the future of reproductive medicine as we see for the next 10 years, at least 10, 15 years? Where do you see the way we have
I
grown
would
and
see
much?
that the smaller centers will shut down. Because at the moment, those single centers are being gulfed by the bigger predators of corporate, that is the foreign investments. But the foreign investment people don't understand. They don't understand the subtle nuisances of IVF. They just pump in the money and that bubble will burst. It's already started. And secondly, they are diversifying themselves because they're either getting into the pharma or they're also getting into the drugs, the small molecules, and they're getting into mother and child. So what happens is they're trying to look for extra income to maintain the EBITDA. Okay. This third party reproduction will come almost to a standstill by approximately another 20 years when they have artificial sperms for man, artificial eggs for woman. So a woman can also make sperms on her own and a man can make eggs on his own. So where is the point? That is not good. And you can grow your organs. You can grow your uterus, have a scaffold, You can grow with the fibroblast cells, and there's no rejection. There is no steroid to be given. And you can fit that inside the uterus in the area in the pelvis, and she will start menstruating. There's no question of taking that uterus out or telling her this thing, and she can then have her own baby. MRK syndrome will be a thing of the past. Okay? And then you look at all the whole genome sequencing, then there is no trial and error, Nina. You put your finger inside and it will tell your genome sequencing by how many ampules this person needs. Is this person allergic to that particular drug? Or what is her probability of getting pregnant? It will give you. Think right out. So there is no trial and error. I'll give 150 units now or I'll give 300 units now. So when all things come, this with artificial intelligence will tell you, look, your trial and error 6 times, etc. is not required. The trial and error is taken off by AI. That is the one. And all the embryologists will have to forget because the robots will take over all that. So all the people who are putting those single centers are closing down. I had 6, 7 centers coming to me to take over. You see, if it is a car, you'll have a resale value. Well, what they'll do with the incubator? What resale value you'll get? Okay.
Certainly, it's futuristic, and I see the future is really bright with technology, AI. I think you can really, really reap the fruits of all the hard work these technological advances are doing. So I think we're just coming close, but I think before I close, I always would love to ask this question to all my guests, and I think you will have to do this as well. So how would you define success in medicine? And I think this is something which is very, very inspiring because these words are important for our youngsters. Success as in not just professionally, but success which is personally, because that's, I think, which message that you leave will really, really, really echo today's podcast, and that's what you want to end this podcast with, this message.
For me, success is a state of mind which sort of gives you a satisfaction, whatever it may be. It may be small, it may be big, but it gives you a state of mind that I have done my best. And when you do something and eureka, you have done it right and you've achieved your objective. But success does not always mean positive result. The journey is as important as the destination. And I am very much for the journey, because if your journey is not right, the destination will be wrong. So everyone says, I've got this thing or that this thing, results. But if that journey is wrong, that will end in a miscarriage. If the diabetes has not been controlled or the hypertension not been controlled, you say, chalega, ye chalega, wo chalega. This chalega attitude has to go. So success for me is meticulous planning and making sure that at the right time you're taking it, not just because you've got less cases today and somehow you want to make the numbers up. Very often I see people cutting corners and then saying, keeping half of the money so that they'll come for the next cycle. You see, these kind of practices will not get you further. What will get you further is to properly analyze the case, whether the failure was in your center or in any other center. The patient is a patient. Don't try to, sort of use her as a guinea pig. Because the person who's sitting in front of you could be your own mother, sister, sister-in-law. Would you do that? And if the answer is yes, then go ahead and do it. Because for me, my reputation, credibility is more important than any money can buy. Because I always have students around me, at least a dozen students. So whatever I preach, I practice. And any unethical practice I put down. Unethical advertisements, etc. So when you say success for me, it's very situational. Very situational. Result is only one of it. It's a state of mind when I can get back home and put my head on the pillow and I'm fast asleep. That is success for me. And every day is the best day of my life. I don't go back thinking and scratching my head, which is the best day of my life. Every day is the best day of my life. And that's how I take every day as it comes. Nobody knows when the end comes. But I'm ready for it because I don't have any skeletons in the cupboard to say I will do it tomorrow. So I don't leave anything for tomorrow.
That's the right way to put it. And I think thanks for being so honest and giving the right kind of message, what is needed for our aspiring trainees and youngsters. I know I wish we could go on, and I know we've been committed by the so-called 45 minutes. We've definitely gone beyond that, and we succeeded and gone to almost 1 hour. I think it's been wonderful to have you, to really look up to a person, and it's been an honor and pleasure to have such a celebrated guest. Thank you once again, ma'am. Thank you very much.
Thank you very much.
Thank you.
Yeah, thanks.